A child is diagnosed with vesicoureteral reflux. Does that automatically mean daily antibiotics? Not necessarily. Continuous antibiotic prophylaxis can reduce recurrent urinary tract infection in selected children, but the decision should not be based on the VCUG grade alone. The clinically relevant question is, what is this child's actual risk of another febrile urinary tract infection? In this video, we will build a practical, risk-based approach to antibiotic prophylaxis in children with vesicoureteral reflux. Vesicoureteral reflux is a heterogeneous condition. Some children have low-grade reflux, normal kidneys, no lower urinary tract dysfunction, and no recurrent infection. Others have high-grade bilateral reflux, renal abnormalities, recurrent febrile infection, or bladder and bowel dysfunction. These children do not have the same risk. Therefore, continuous antibiotic prophylaxis should be viewed as a risk-modifying strategy rather than an automatic treatment for every refluxing ureter. Selected asymptomatic children with low-grade reflux may be managed with close surveillance. Prophylaxis remains reasonable when clinically important risk factors are present. The RIVUR trial remains one of the most important randomized studies in this field. It included 607 children between 2 and 72 months of age with grade 1 to grade 4 reflux diagnosed after a first or second febrile or symptomatic urinary tract infection. Children received either daily trimethoprim sulfamethoxazole or placebo for 2 years. Prophylaxis reduced the risk of recurrent urinary tract infection by approximately 50%. In absolute terms, recurrence occurred in about 15% of children receiving prophylaxis, compared with about 27% receiving placebo. However, prophylaxis did not significantly reduce new renal scarring during the study period. It was also associated with more resistant organisms when breakthrough infection occurred. So the RIVUR trial did not show that prophylaxis cures reflux or prevents all renal injury. It showed that prophylaxis reduces recurrent infection in an appropriately selected population. The benefit of prophylaxis is not uniform. Risk is generally higher in children with recurrent febrile urinary tract infection, high-grade or bilateral reflux, bladder and bowel dysfunction, lower urinary tract symptoms, abnormal kidneys or established renal damage, younger age, and limited access to rapid assessment during fever. Children with bladder and bowel dysfunction may derive particular benefit because dysfunctional elimination increases the probability of infection. The practical principle is simple. As baseline urinary tract infection risk rises, the potential benefit of prophylaxis also rises. Observation without daily antibiotics may be reasonable in a carefully selected child. A typical lower risk profile includes low-grade reflux, normal renal anatomy, no renal scarring, no recurrent febrile urinary tract infection, no bladder and bowel dysfunction, reliable caregivers, and rapid access to urine testing and treatment during fever. This is not passive observation. It requires active surveillance, clear fever instructions, prompt urine culture, and reassessment if the clinical pattern changes. The absence of prophylaxis should never mean the absence of follow-up. Bladder and bowel dysfunction is one of the most important modifiable factors in children with reflux. Constipation, infrequent voiding, urgency, withholding, incomplete emptying, and daytime incontinence can all increase urinary infection risk. In a toilet-trained child, reflux management should therefore include a deliberate search for lower urinary tract dysfunction. Treating reflux while ignoring dysfunctional elimination is incomplete management. Initial treatment may include timed voiding, adequate hydration, constipation treatment, proper toilet posture, and further bladder assessment when indicated. Treat the bladder and bowel, not only the ureter. There is no universally accepted age or VCUG grade at which prophylaxis must be stopped. Discontinuation should be individualized. Factors supporting cessation include a prolonged infection-free interval, successful toilet training, resolved bladder and bowel dysfunction, lower grade or improving reflux, normal renal status, and reliable access to urgent medical evaluation. Factors supporting continuation include recent febrile infection, persistent high-grade or bilateral reflux, ongoing bladder dysfunction, renal abnormalities, or poor access to rapid urine testing. Stopping prophylaxis is a clinical decision, not a calendar date. A practical approach can be summarized in 5 steps. First, confirm the clinical phenotype. Was the reflux detected after a febrile infection, after antenatal hydronephrosis, or incidentally? Second, define infection risk. Review age, reflux grade, laterality, previous febrile infections, renal findings, sex, circumcision status, and access to care. Third, assess bladder and bowel function. This is particularly important after toilet training. Fourth, select management. Use prophylaxis when the expected reduction in infection risk is clinically meaningful. Use structured surveillance when the child is genuinely low risk. Fifth, reassess over time. Reflux grade, bladder function, infection frequency, and family reliability can all change. Management should change with them. 3 take-home messages. Number 1. Not every child with vesicoureteral reflux requires daily antibiotics. Number 2. Continuous antibiotic prophylaxis reduces recurrent urinary tract infection, but has not consistently been shown to prevent renal scarring. Number 3. The decision should integrate infection history, reflux severity, renal status, bladder and bowel dysfunction, age, and reliability of follow-up. The best question is not, does this child have reflux? It is, how high is this child's febrile urinary tract infection risk, and which parts of that risk can we modify? This is Pediatric Urology Academy. Subscribe for the next lesson on bladder and bowel dysfunction and recurrent urinary tract infection.